want to thank the organizers of this conference for asking me to talk on the emerging PET radiopharmaceuticals and therapy. I find it is great pleasure and I want to deliver this one. I'm not focusing on a number of new emerging PET radiopharmaceuticals. Instead, I'll be focusing on a selected few of them and see what we can benefit out of these radiopharmaceuticals. So before I go further, as a radiochemist, I want to see the advantages of using organic chemistry versus the coordination chemistry. Organic chemistry, most people know, is a typical example is preparation of F18 labeled FDG, which is achieved by replacing the hydroxyl group with a F18 radionuclide. It's a series of reactions happening before you get this one, and that shows the complexity of this process. So the advantage of this one is to see minimum disruption to the structure. So it behaves like the parent molecule when you're making the radionuclide. So it is very close to the metabolic cycles. So there is not much of an influence with or a difference in the structure of the molecule. On the other hand, using the coordination chemistry, which has been very popular in the last decade and a bit, you see that vector molecule binding the receptor protein is modified for binding gallium, lutetium, or yttrium, or a number of radionuclides via a bifunctional chelator. So this has become very useful because not only diagnostic information, but also followed by the therapy also can be performed using this particular arrangement. The real underpinning strength behind the theranostics is in the development of these bifunctional chelators. Say, for instance, if you take gallium DOTA, it is satisfying all the 6 valencies, and with yttrium DOTA, it is satisfying all the 8 valencies, 4 nitrogen and 4 carboxyl, here 4 nitrogen and 2 carboxyl groups. So what it all means, it provides you with a stable kinetic, thermodynamically stable, kinetically stable, and metabolically stable radionuclide complex you get at the end of by the macrocyclic, using the macrocyclic bifunctional chelators. One of the problems with this one, it is well suited for tumor imaging on therapy, but unfortunately this cannot be employed very much beneficially for brain imaging purposes, because you have the blood-brain barrier with a lot of bulky substitution. It will not go into the brain. And then you can see these are the most popular, most commonly used bifunctional chelators like DOTA, NOTA, and its derivatives like MODAGA and FRAC. All these molecules, all these chelators are very, very useful in developing various ligands for imaging cancer. And one of the products, which is gallium somatostatin analog, like DOTATATE or DOTATATE, has been extensively used for neuroendocrine imaging. But for neural crest tumors and gastroenteropancreatic neuroendocrine tumors, these are the 4 commonly used radionuclides like F18 F-DOPA, iodine 123 labeled MIBG, gallium antagonist, and F18-FTG. I just want to highlight, how these radionuclides, although they are working quite nicely, there are several limitations and difficulties associated with this one. I want to just provide some example to see how gallium dotatate can be useful instead of using these radiopharmaceuticals. So FDOPA is a superior diagnostic agent in a limited number of precise neuroendocrine tumors like medullary thyroid cancer, etc., etc. But preparing FDOPA is a nightmare for the radiochemist. It is not only expensive, but it's also very time-consuming with a low yield. And that's the reason, and with all these things, this particular study is comparing the utility of F18-DOPA against the gallium DOTA. And you can see F-DOPA is able to pick up only a couple of lesions. On the other hand, gallium DOTA is very efficient in picking up many more additional lesions in the liver and in the soft tissues and the lymph nodes. So this is in the patient with the gastroenteropancreatic and lung neuroendocrine tumors. Similarly, if you take in a well-differentiated metastatic neuroendocrine tumors, FDOPA has got a clear role. As you can see, it picks up more lesions and also very avid uptake. On the other hand, with the gallium dotatate, the lesions are identified, but quite a few lesions are missing. But the intensity of the uptake is not really as good as it is in FDOPA. So in well-differentiated metastatic neuroendocrine tumors, FDOPA is the way to go. And on the other hand, you can see in a well-differentiated carcinoma, more receptors and low metabolism. So that's the reason why you can see FDOPA is positive because we have more receptors, and gallium dotatate is also positive because of more receptors. And low metabolism, and that's the reason why FDG is not very useful in a patient with increased calcitonin and CEA level after surgery for the MTC. On the other hand, if you take fully differentiated neuroendocrine tumors, less number of receptors and high metabolism. So as we expected, because of the high metabolism, the more lesions are identified using the metabolic agent, which is F18-FTG. As you can see here, very intense focal uptake. On the other hand, FDOPA and DOTATATE are not able to identify many lesions, although some faint uptake are shown in the sternal area. So this summarizes in a cancer metabolic so it summarizes, there is no one particular radiopharmaceutical can be used right across the spectrum of diseases. So it is dependent on the condition of the differentiated or undifferentiated, differentiated or poorly differentiated metastatic status of cancer. So MIBG is another one agent which is used for neuroblastoma. So in this particular situation, it's a patient identifying a malignant neural crest tumor using MIBG versus gallium dotatate. As you can see, MIBG is the gold standard for imaging neural crest tumors and neuroblastoma. And you can see, it's a very low-grade uptake is shown using the MIBG. On the other hand, using the gallium dotatate, extensive metastatic lesions are identified, not only corresponding to those two lesions, but also additional lesions in the lymph nodes and the soft tissues. And for a start, MIBG is very expensive. As we have to import this radionuclide, it becomes about $2,000 to $4,000 per dose. And here, if you have a generator in-house, it costs next to nothing, but also it gives you much better information. You can see it further, comparing the MIBG with somatostatin imaging with a DOTATATE or indium DOTATATE. You can see much better identification of the lesions. So it all shows, it is not only using the gallium DOTATATE is not only cost effective, but also more efficient in identifying the lesions associated with these kind of paragangliomas, head and neck paragangliomas, etc. So we have seen few examples, how gallium-labeled DOTATATE or somatostatin analogs are useful in imaging many types of cancers. And now we want to see, what is copper-64 is a new kid in the block. And copper-labeled DOTATATE has been used, to see, if it can replace gallium DOTATATE, which is the established gold standard for neuroendocrine tumors. Due to the half-life of 68 minutes for gallium-68, it has some limitations, and that's the reason why copper with a longer half-life is examined for the suitability, especially for theranostic applications for neuroendocrine tumors, for estimating the symmetry and therapy planning. And this group of have studied copper DOTATATE in a patient with known suspected somatostatin receptor positive neuroendocrine tumor. As expected, it's identified a number of metastatic lesions, quite nicely. Similarly, Pfeiffer et al., they have come up with the same copper DOTATATE and identified and compared it with the indium octreotide, and then they could demonstrate copper DOTATATE is much superior in identifying a lot of lesions. They also did something using the long half-life of the copper, not only studied 1 hour imaging, but also delayed imaging at 3 hours and 24 hours. As you can see, these lesions are washed away from the metastatic lesions in the liver, and also the liver activity is increasing with time. So this is a very bad example of using the theranostic or a therapy agents, because of the wrong dosimetry associated with kind of investigation. So poor late retention of copper is known in known tumor deposits. This is severely constrains the ability to do prospective dosimetry or therapy because of this problem. So this kind of information was not available when we are using only gallium DOTATATE as the investigative process. So copper-64 and copper-67 theranostic SARTate has been developed by Clarity Radiopharmaceuticals, and they define the SARTate as a first-class, highly targeted theranostic radiopharmaceutical which can image, perform prospective dosimetry, and subsequently treat cancers that express somatostatin receptor. And that's the bird cage structure, which captures the copper-64 or copper-67 very, very nicely in here. And the mechanism of action, it clearly shows, that it's got a peptide, it has got the metal ion and also the chelator, which is sarcophagein, and then it makes a very tight complex. So once injected, it's targeting the tumor and binds, internalizes, and delivers radiation within the cancer cell and breaks the DNA. So this particular mechanism is very useful because when it is therapy is delivered, the DNA strands are broken, and which is a very, very useful thing, for delivering the therapy in a very effective way. And the first studies are done by Peter Mack group in collaboration with this agent, and you can see the tumor uptake is increasing with the time in the liver lesions, and on the other hand, using the copper DOTATATE, it is decreasing. So copper sartate allows the prospective dosimetry for therapy because it's not only retaining the lesions in the delayed images, but also the liver activity is washed away, which is the most desirable quality which is expected of a theranostic agent. So the Peter Mack used a comparative study demonstrated that at 1 hour into 1 hour post-imaging, they demonstrated whether it is using gallium gatate or copper sartate, the lesions are identified quite similar, but in the 24-hour, there is no liver interference, and there is an avid uptake of the agent in the particular tumor lesion in the liver. So this shows, the advantage of imaging using copper sartate, the delayed imaging like 20 hours, it's a certain advantage in this one. So the major impact on the definition of small intrahepatic metastasis. And also they have shown in an unresectable pancreatic primary being considered for the neoadjuvant, PRRT, the borderline renal function, high tumor retention, and late liver clearance, as you can see it over here. Very high retention in the tumor that makes it a very desirable one, and therapy planning makes it very, very easy. So in conclusion, copper sartate leads to stable binding and high retention in tumor sites, and clearance from the liver activity enhances the lesion definition with the most intense lesion to liver ratio more than doubling within 24 hours. Acceptable radiation dosimetry for diagnostic use, which is only 3.1 millisievert per 200 MBQ. So these are all the real merits of using copper sartate in adult patients. And also, they have taken it one step further, using copper-67 as a therapy agent for meningioma, which is done in collaboration with the Royal North Shore Hospital with Dr. Shembri and Clarity Radiopharmaceuticals. They have clearly demonstrated using the copper-64 sartate or copper-67 sartate, similar lesions are identified, as you can see, and delayed images not only retain them, but also shows that. So this is a clear evidence that the preliminary data are showing it accumulates in the meningioma very nicely without any background interference. Some groups in Europe, especially in Italy and Mexico, they have used copper radionuclide, copper-64 radionuclide as a theranostic agent. In the preclinical studies, the mouse with a tumor, you can see, uptake is very, very nice, and it is retained over a 20-hour period, which is very, very desirable. And also, when they used at a very high concentration of copper as a theranostic agent, the tumor, which is present in a very big, is a huge, significant volume reduction has been reported. So these findings are clearly identifying copper-64 as such can be used as a diagnostic agent and also as a therapy agent. So it's a Potential for this for this radionuclide is there as a theranostic agent, but undesirable dosimetry in the liver is one of the major problems, which is encountered using copper 64 without any carrier. So next, I want to focus and identify some merits in developing a new dopamine transporter, which is F18, which is provided to us the courtesy of Vijay Kumar from Positron Pharma in Chile. And we have developed this one in collaboration with them, and I want to show you some evidence as why it is a useful, nice agent. So this is a F18 transporter, presynaptic, and there are several presynaptic dopamine transporters are there, and we wanted to evaluate how this is going to be useful. And we do have vesicle transporter, dopamine storage ones, and dopamine receptors binding. But we are going to focus on development of F18 PRO4 to see how it is useful for imaging imaging dopamine transporter. There are several established tracers are available in the market. 6 of them are C11, 2 of them are F18, 2 of them are the old ones with iodine SPECT agents, iodine 123 and technetium. So amongst this one, the most dopamine transporter ligands have non-specific binding to off targets. So when you're trying to image dopamine transporter, serotonin transporter is a possible interference because of the high non-specific binding and high non-specific binding and also low target to background ratio. So these are all seen as the problems or the limitations with the existing agents. On the other hand, this particular group has evaluated not only the conventional one, but they have developed 3 different agents called PRO4, PRO4 and PRO6 and PRO17. And you can see they selected this one for the reason because it has got the highest affinity for the dopamine transporter and very low affinity for the serotonin transporter and neuroendocrine tumors and all the other things. So all these parameters are in favor of this one as a very useful candidate for dopamine transporter imaging. So that is the 4 analogs they have developed, and they selected this one because they have the highest affinity for the dopamine transporter. And in the preclinical evaluation, they have done the binding studies in a baboon, and you can see very avid uptake in the basal ganglia, and they could effectively and completely block it with a blocking agent. And in the midbrain, you can see all the caudate and putamen activities are all shown in the preclinical studies. So to make it proof of principles a bit more solid, they have selected the normal human controls and your mild patients and your advanced cases. And they have demonstrated in the normal control, caudate and putamen activities are all completely intact. In the mild HANYAR patients, you can see there is still a lot of compromised activities in the putamen, but caudate activities reasonably retained. And HANYAR 3 and 4, which is the advanced stage, almost all the putamen activities completely washed off, and also the caudate activity. So as it is expected clinically, it's corresponding to the amount of binding is very much corresponding to the severity of the disease. So this is a proof in principle that this particular agent is a good one for using the Parkinson's disease. And accidentally, they identified the micro-calcifications can be detected using this agent. You can see micro-calcifications, which is an incidental finding, and it is very useful in case you have to do this one. One other clinical condition is the Holmes Tremor. You can see Holmes Tremor is characterized with a patient with a sudden onset of the left hemiplegia, secondary to mesencephalic hemorrhage, and a progressive left side low frequency rest, postural and action tremor. He exhibited marked reduction of tremor with the levodopa and carbidopa, and as expected, there's only one side it is completely compromised, both caudate to some extent, but a great extent in putamenal activity. Only one side, on the other side it is completely normal. So this is a typical example of hemiplegia secondary to the mesencephalic hemorrhage, characterized as the Holmes tremor, and it is a very useful agent in this kind of a situation. The group also, another group has studied F18 DMFP as the post-synaptic dopamine transporter for differential diagnosis of Parkinson's disease, multiple system atrophy, and the progressive supranuclear palsy. And you can see in the control patient, the caudate and putamenal activity is intact. In Parkinson's, it's almost intact. But in the probable PSP patients, you can see caudate activity is compromised, but not the putamenal activity. So this is quite distinct from the Parkinson's disease. Using that dopamine transporter, you can see there's a clear distinction. In the PSP, it is the caudate, but in the dopamine transport, it is the putamenal activity which is compromised. So this is a very useful marker. A lot more information is available now, and this is a post-synaptic dopamine transporter, as we can see it here. And also the postsynaptic D2 imaging in Parkinsonism, you can see this particular agent is quite useful in a patient A with a non-IPS and in patient B, which is a decreased receptor binding. So this summarizes, there is a particular role for the DMFP, which is F18 label, which can be used in non-idiopathic and idiopathic Parkinson to differentiate. You can clearly see that in a patient 1 with a non-idiopathic Parkinsonism, there is a putamenal activity is very badly compromised, but on the other hand, it's the IPS, which is the idiopathic Parkinson syndrome. The both caudate and caudate activity is more compromised than the putamenal activity. So this is one and another way this can be distinguished one from the other. Another thing I want to focus after the brain imaging agent is something we're all looking forward to, is to image insulinomas. So exendin 4 has been implied and used by many groups, and it's a courtesy of Martin Gottschalk, who provided me a few slides, and they are using Nodaga as the bifunctional chelator, which is gallium bound, and they evaluated the usefulness of this particular agent for imaging insulinomas. So the insulinomas binding to GLP-1 receptor, and that is the exendin 1, exendin 4, which is the amino acid sequence, which can be radio-labeled, and it binds to the GLP receptor in the beta cells and labeled exendin binds onto this one, and that is the mechanism behind this particular agent. So they have compared quite a few patients. There's only a preliminary studies from Netherlands. CTMR, somatostatin receptor PET-CT, and exendin PET-CT. You can see CTMR has got very limited use because you have a lot of limitations associated with this one. On the other hand, somatostatin receptor is useful more often, but there is no tumor visualization in some particular cases, and multiple lesions are resolved. But on the other hand, using exendin, you can see lesions are identified in all 5 groups of the patients. So that's the reason why they propose that DAGA is the way to go for preparing the exendin 4. So comparing a patient with MRI and gallium dotatate insulinoma, you can see MRI identifies, which is identified the gallium dotatate PET-CT as well. But there is a lot of interference from the surrounding tissue, especially liver. But using exendin 4, the same lesion is identified without any background uptake by the liver, and also the uptake around the tissue. It is really very specific and identify the lesions, insulinoma lesions, quite neatly. And DOTATATE PET-CT, you can see it is missing, obviously. It's not able to identify. On the other hand, using the gallium exendin PET-CT, they could identify insulinoma lesion quite positively. And all these lesions were further substantiated by having the biopsy taken from these patients. And that's the reason why they have concluded this one, biopsy proven positive results with exendin 4, which is more useful and more specific, and the image quality is more superior to the other agents. So in conclusion, gallium exendin 4 performs better than standard imaging methods. Image quality of the gallium exendin 4 is better than somatostatin receptor imaging like DOTATATE or DOTANO. Gallium exendin 4 is a promising new technique for non-invasive preoperative detection of insulinomas. This is a real advantage. We will hear more of this particular agent in the coming. There's a lot talked about gallium-labeled FAPI, which is the fibroblast activation protein inhibitor. I'm not going to focus too much on this one because it's been covered by elsewhere in the other talks, but it is an incredibly promising agent as the fibroblast activation protein is highly expressed in stroma of several tumor entities, especially in these kind of tumors. Fibroblasts are present ubiquitously in the whole body, but very slow, show very low FAP expression. In contrast, cancer associated with the fibroblasts are specifically characterized by overexpression of FAB. And that is 2 analogs, FAPI2 and FAPI4. And the only difference is the 2 fluorine substitution over here. And as you can see, FDG PET identifying tumor lesions in many cancer conditions, and the gallium FAPI PET is also showing all the lesions, which is identified this one. So irrespective of the cancer lesion, FAPI can really identify the lesions, very effectively. And also comparing the 2 analogs, the FAPI2 is taken up and it is washed off quickly. On the other hand, FAPI04 is retained, uptake is quite avid, and also it is retained on an extended period over 3 hours imaging time. I'm not going to spend too much time on this one because it is very extensively covered in many places and many other speakers in this conference. So I got to just focus a little bit on the therapy and therapy monitoring in the last 10 minutes of my talk. So current therapy options are lutetium DOTATATE, which is a beta emitter, lutetium PSMA, a beta emitter again, actinium is an alpha emitter, and yttrium is used for the solid tumors, and also radium is used, which is another alpha emitter. It's very expensive, and lutetium BP-AMD zoledronate for the bone palliation. I'm not going to cover everything, but I'm going to show a few of the useful applications of the current therapy options. And also the new avenues to improve the PRRT in future, using the tandem PRRT, the concurrent lutetium and the yttrium PRRT, or combined PRRT with other treatment modalities like chemotherapy, using these agents, kinase inhibitors, intraoperative use of the probes after the PRRT with the lutetium, and intra-arterial injection. These are all the combined PRRT with other treatment modalities. There are applications in the specified conditions, and also the application of alpha emitters has been quite extensively, quite more and more prevalent in where the lutetium-labeled DOTATATE is not very effective. Actinium-labeled PSMA is much more effective, especially in the PSMA, it is demonstrated quite extensively. And also the antagonist peptides are available, and bisphosphonates are again used not only as a palliative agent, but also as a therapeutic agent. So the macrocyclic bisphosphonate for diagnosis and endoradiotherapy of bone metastasis, which is provided by courtesy of Frankfurt from Germany. So he clearly demonstrated using an MDP and binding that with the DOTA, you get the BP-AMD. Binding that with the gallium, you get a PET diagnosis, identifying several lesions, bone metastasis especially. And then by replacing gallium with the lutetium, you get the endoradiotherapy. Almost all these bone lesions are again identified, bone metastasis. So this is a theranostic tool using either gallium or lutetium. It is not only very useful for diagnostic purposes, therapy also, and also for palliation. In patients with the 3 and 4 stages, palliation is more important, and lutetium bisphosphonate can act as a palliative agent in this case. One of the advantages of developing this one, you can see the tumor uptake, the femur uptake is very high, and the kidney uptake is very low. So when you're using the therapy agent, the kidney will have a very low radiation burden. So there is a very minimum kidney damage, patients who are treated with the BP-AMD or any other agent. So they have very clearly demonstrated using the lutetium BP-AMD post-therapy planar images showing in patients with the metastatic prostate cancer at 5 different time intervals. You can see uptake is already visible in 30 minutes, very little soft tissue background, and which is retained for over 68-hour delayed images, showing all the lesions are still taken up the gallium labeled tracer and retained in those tracers, and also the lutetium BP-AMD is quite well taken and retained at the delayed images. So in summary, it shows that lutetium BP-AMD therapy using the 3.5 to 6.4 GBQ of the activity, there is no adverse effect in any one patient they have studied. And the mean absorbed doses were calculated as follows. Skeletal metastasis, showing almost all the radiation is associated with skeletal metastatic lesions. The whole body, kidneys and red marrow is showing very little activity, showing this agent is very useful theranostically. And very long residence in the skeletal metastasis because of the T-half of lutetium of 6.7 days. Therefore, lutetium BPIMD has excellent dosimetry characteristic for the treatment of skeletal mets and very low toxicity potential. And they have now studied with the lutetium DOTA rather than BMD. They use the zoledronate, which is the much more avid binding agent, for the bone mets. And they treated that with the prostate cancer. And as you can see, the baseline level of PSA was 1200, which fell to 88 within the 8 weeks post-therapy. And then 18 weeks later, it's fallen a bit further. And also it clearly shows, all the extension, all the metastatic lesions have taken up and retained, for extended period. So there is a place for DOTATATE, the lutetium DOTA zoledronate, and as a very, very effective agent for treating the bone mets and for palliation and for therapy. So targeted alpha therapy again has been quite extensively used, and everyone quite is aware that the 3 sittings of the actinium labeled PSMA completely resolved all the lesions associated in this particular patient, and another one more treatment further reduced the burden. So in this patient, the PSA level was in response to 2 treatments with the lutetium PSMA. It was progressive, the disease was progressing, and the same patient, after treating with the 2 sittings of the actinium PSMA, the disease is resolved extensively, and another one more treatment further resolved it. And then you can see here pre-therapy and post-therapy, there is a big advantage in having the bismuth, which is another alpha therapy. So this summary summarizes the advantage of using the alpha therapy, not as the first-line therapy, but as the second-line therapy, where the lutetium PSMA is not really effective in treating these patients. So, in summary, in my talk, I have given the difference between the organic chemistry and coordination chemistry, the driving force for the rapid development in somatostatin and PSMA-based theranostic approach. I have highlighted the driving force behind that. Will the new gallium-based PET radiopharmaceutical replace some of the SPECT imaging gold standard radiopharmaceutical like technetium-labeled agents? And I have highlighted why copper-64 is an important radionuclide and potential for copper-64-67 sorted for the theranostic approach. And the latest on the new kid in the block, FLATI, and F18 DAD for dopamine transporter imaging, gallium GLP-1 receptor-based imaging for insulinoma, and new approaches for theranostics, combination of all these things, the bisphosphonate for theranostics, and combination of PSMA DOTA BP for therapy and palliation. So these are the few examples I have given to highlight the emerging new PET radiopharmaceuticals and for therapy agents. With this, I want to thank you for your attention and thanks for giving me the opportunity to speak in this important conference. Thank you very much.